Middle East or Asia.
Thing is, so this one actually we can.
And needles coming from distal.
Tendon moves together.
The tendons that is being stabilized by this pulley system. Good morning from where we are and Dr. Raul, and good evening to our guests and visitors from Asia. We would like to welcome you all in this mask ultrasound Zoom lecture. And today we are privileged to welcome our guest speaker, who is one of the professor in the Mayo Clinic in Florida, and at the same time he's a specialty in physical medicine, rehabilitation, sports medicine. I met him for the first time in New Orleans just last November, and we agreed to ask him to actually give a lecture today. And we're extremely happy that he found time to really give a lecture on this unique topic about breast cancer and upper extremity complaints with MSK ultrasound applications. So without further ado, I would like to welcome today Dr. Raul A. Rosario Conception. He's a doctor of physical medicine rehabilitation based in my clinic, Florida. So good morning, Dr. Raul. Welcome to our forum today, and we're glad to have you in this lecture. So welcome. You may
Thank
now.
you. Thank you very much for the invitation. I'm going to be talking a little bit about one of the things that I'm doing in my clinic, which is kind of very interesting, how kind of I have combined a little bit of my sports medicine knowledge and applied in the breast cancer population to try to help them through and improve their quality of life. So I have no financial relationship. So the objective will be to discuss the importance of cancer rehabilitation and how physical medicine and rehabilitation physician and a lot of multiple specialty can actually help patients with cancer improve their independence and quality of life. And we're going to discuss why I think that more PM&R and sports provider can help patients with cancer. And we're going to be talking about the most common upper extremity musculoskeletal problems that patients with breast cancer have after their treatment that will be amenable to rehabilitation and procedures that it will help their quality of life. So first of all, I tend to start like, why do I see breast cancer? I'm a sports doctor, right? I did PM&R, but I focus in seeing sports medicine and athletes, and I do a lot of ultrasound in my practice. Why do I start developing this interest in helping patients with cancer, especially breast cancer? And one of the big things is that these patients are living longer because of the advances in the medicine and the surgeries and the treatment. But that means that they're developing more problems due to the complication from their treatment, and this decreased kind of the quality of life. And one of the biggest problems that I notice is that the cancer specialists, like some oncologists and surgeons, really don't understand what is the kind of the importance of the rehabilitation for their patient and how can actually we can make a big difference improving their quality of life. And I hear a lot from patients that their providers and doctors just when they complain of a shoulder pain or issues, they just say that this is going to be your new normal and we just have to get used to it, which is something that I don't like because there's a lot of options that we can offer patients to try to improve their life. And for that reason, in that case, since they don't have that knowledge, rehabilitation and other modalities are not offered as part of their treatment. On the positive side, I feel that cancer patients actually want to get better, which is not the case in some patients that we see in PM&R. It's very kind of refreshing to see that you actually recommend something and they kind of very excited to try to follow the recommendation in order to get better. And they're very appreciative about the recommendation that no other doctor have done in order to improve their symptoms, their pain, or different complaints. So just to put this into perspective, I'm hearing here in the United States, there's 17 million cancer survivors, and which is a number that expect to exceed by 2030 to 22 millions. And the life expectancy of at least 5 years in the 50s were 35%, in the 70s 49, and in 2020 was 70. So more people are surviving with this diagnosis. And at least 50%, and in some studies, closer to 90%, will experience some type of impairment or complaints resulting from the cancer itself or the cancer treatment, which definitely is affecting their quality of life and independence. So here in the United States, there's a big push to try to optimize the training for cancer rehabilitation, as we call it. But right now, the fellowship, there's 11 fellowship that especially one extra year after training that you can get additional training in this population, still not recognized by the board, but hopefully in the future it will. But the problem is that there's a lot of patients with cancer that need care, and we cannot wait until people are trained in this fellowship. So other PM&R providers and even sports doctor like me, we need to step up and try to help these patients in order to provide a better care in their needs. So now talking a little bit more specific of why we're here and talk about specific complications that I see in the musculoskeletal field in patients with cancer. The first point that I always try to make is that we need to identify where the cancer or where the pain is coming from. The most important thing is that is the pain coming from the cancer itself, or the pain is coming from the treatment of cancer, or it's just not related to the cancer at all, and it's just a benign degenerative changes that we see in other patients. So the first point is that I always tell is like, make sure that it's not the cancer, it's not metastasis in the bone. For example, this is a patient of breast cancer that came to my clinic. She had like very poor follow-up. She came from this kind of shoulder pain and upper extremity pain. But when I saw the patient in my clinic, she came limping with a cane. So as a PM&R provider, I kind of noticed and asked her questions of since when you're using the cane. And she said like since 3 months ago when I had this pain in the hip. So when a patient with cancer, that's kind of a red flag for me that we need to investigate to make sure it's not metastasis, which was the case on this patient. We did an x-ray and it shows some lesions here in the right femur shaft and in the acetabular kind of region on the left side. And when we did like more further study with the bone scan and MRIs, we can see like a lot of metastases here in the left acetabulum and in the femur bones and all around the spine. So we were able to identify these metastases in the clinic by just asking questions and trying to help with their pain. And we kind of sent to the oncologist to kind of readdress and create a more specific treatment program for them. However, this is not the case that we see in my clinic all the time. Actually, these are the conditions that I see in my clinic with patients with breast cancer specifically. And most of these conditions are things that we see in other patients. So most of these are not kind of specified to the cancer population, and all of us know how to treat these conditions. However, there's a few things that are very specific for the breast cancer patients, and those are the things that I want to address today and touch base in terms of give you my perspective of how I treat them, but also how I kind of correlate with the ultrasound practice, how can we help them. So the first things that I want to do and talk a little bit about it is shoulder dysfunction and impingement syndrome, because this is something that I see a lot in my clinic. After surgery and after radiation, the patient can produce painful scar tissue that can decrease the biomechanics of the shoulder. There's going to be some shortening of the anterior chest wall involving the pectoralis major and pectoralis minor muscle, which is something very common that I see, that can produce some protraction and forward depression of the shoulder, creating a kind of weakness in the posterior shoulder blade muscles and create this kind of imbalance that can create impingement in the shoulder that we can see in other patients, but in this case is secondary, most likely from the surgery or radiation treatment. The treatment for this usually is exercise, rehabilitation, improving the biomechanics, optimize the stretching of the pectoralis muscle, optimize the strength of the periscapular muscles. And then sometimes we can control the pain with oral medication or injections. But I feel that with the idea of the patient can tolerate better the rehabilitation and the stretching program, which is going to be the main treatment for these patients. So I always try to bring this because this is something that I see in almost every patient that we need to address in order to decrease the shoulder pain. The other condition that I see a lot is axillary web syndrome or cording. Some patient with breast cancer that has surgery, and especially when they have a lot of lymphatic and lymph node dissection, they start developing this kind of palpable cord-like subcutaneous tissue that you can see here in the image in the arrows, that is basically a sclerotic kind of lymphatic vessel that travels in the arm that I feel that is not being used anymore because we took the lymph nodes out, and then they become fibrotic, and it can decrease the range of motion of the shoulder. Usually it's not painful, but when you try to stretch your arm and that stretching sensation can create some pain. Usually the treatment that we do for this condition is kind of physical therapy, rehabilitation, do some manual mobilization to kind of break the cord. In some cases, the patient notice like a pain or a pop sensation, and that means that the cord kind of broke, and then the range of motion improved very quickly. So kind of that's the treatment, and it's something that we need to educate the patient because sometimes they don't know what's going on, and it's this condition, web syndrome. One of the other conditions that I see a lot in my practice is the post-breast surgery pain syndrome. We're going to spend a little more time in this condition. And another term for this is post-mastectomy pain syndrome or post-lumpectomy pain syndrome. I have adapted the term post-breast surgery pain syndrome because it's something that it can happen with any type of breast surgery, even the reconstruction surgery, even breast augmentation surgery can and develop this pain. And it's basically this kind of burning, stabbing, and neuropathic pain in the anterior wall, chest wall around the breast, or even in the lateral chest wall over here. And the idea of the reason that the patient developed this chronic pain syndrome that usually we kind of diagnose at 3 to 6 months after the patient has surgery or radiation is when you do surgery, you have to cut the skin and then you have to go through the lateral cutaneous branches of the intercostal nerve that travel superficial and deep of the serratus anterior muscle there in the lateral chest. And then the patient develop this kind of neuropathic and pain that is, they're very kind of sensitive in that area. So they're going to describe that the bra give them pain and trouble. And if they touch that area, it's very sensitive and painful. And this is an important concept because there's a study that says that 52% of women that has the diagnosis of post-mastectomy pain syndrome 4 years after surgery, they still have the symptoms 7 to 12 years after. So it becomes very problematic for some patients that they develop this problem. The other nerve that I want to talk about is the intercostal brachial nerve. That is a nerve that comes from the T2 intercostal nerve at the T2 level and travel towards the proximal arm to the axilla that also can get injured with lymph node dissection that they can develop burning and pain more in the proximal arm in this region. I tend to see more pain in the chest wall than in this nerve region. I feel more that the patient develop more numbness than pain in that area, but that's my personal experience in my clinic. So let's start talking a little bit about how do I manage this patient. So first, I tend to start with kind of a good rehabilitation program. We can use some desensitization techniques, some manual therapy, some massage, which can be very helpful. And then we try to correct the biomechanic that we talk about in the shoulder by providing stretching of the pectoralis muscles and then strengthening of the scapular muscles. If the symptoms do not improve, we have two other options, oral medication or injections. In my experience, patients with cancer are already tired of taking medication and they're not like very a fan of taking any additional medication. They tend to move towards the injection route. But we have the option of considering medication like pregabalin and gabapentin and also duloxetine that can help the patient with this kind of neuropathic pain. Topical agents also can be helpful. And there's some intervention techniques that we're going to talk a little bit more with the ultrasound application that I'm using in these patients, like serratus anterior plane block and intercostal brachial nerve blocks. Before we enter into the procedure standpoint of ultrasound, this is kind of a 5 tiers approach that I have developed. And we're going to hopefully publish an article soon describing the evidence of these options in this population that's currently being reviewed by a oncology journal. But you can get like a sneak peek if you go to PMNR Knowledge Now in the APMNR website and look for the post-mastectomy pain syndrome that we just published a couple of months ago. And it's going to give you a little bit of the tier approach that we use in terms of we start with conservative treatment and rehabilitation first. If it doesn't work, we can always consider oral or topical pharmacological treatment. Then we can consider interventional techniques that we're going to talk a little bit more about those. And there's a list there of options that can be considered. Some patients develop like neuromas, and there's some scar tissue that benefit from surgery. I don't use this approach very commonly, but it's an option. And then if the patients do not improve with any of these modalities, I think some of them have developed what I call the amplifiers of pain. The amplifiers of pain are things that can affect the pain and increase the signal and affect the quality of life of the patient. So 3 very easy amplifiers of pain is poor sleeping patterns, depressions, anxiety, frustration from changes in your mood, and then low level of physical activity. So in some places, at least here in Florida, we have a very comprehensive chronic pain rehabilitation program that is a 3-week program from 8 in the morning to 4 p.m. that we address those amplifiers of pain, and we get evaluation by pain doctors, psychologists, sleep experts, physical therapists to try to address more of a comprehensive manner, and then the patient hopefully can have better results. So now let's start talking a little bit of the more fun aspect of the presentation and start implementing a little bit more of the ultrasound application in my practice. One of the most common injections that I offer patients is the serratus anterior plane block. This is a very common injection that anesthesiologists and regional anesthesia providers offer before surgery so they can numb that area and they can do the surgery. But there's a few articles that there can be a role for the chronic pain syndrome development of post-mastectomy pain that can give the patient some good results. So the idea is to kind of inject the space where the lateral cutaneous branch of the intercostal nerve live, which is kind of superficial and deep of the serratus anterior muscle. So there's 2 potential space. So you can see arrow number there in between the latissimus, which is number A, and number B is the serratus anterior. So in between that space, there's a possible injection that we can do, but also we can inject deep to the serratus anterior in between the ribs and the serratus anterior muscle. There has been done some like only one study that kind of compared the two, and the results were pretty similar. So I tend to do the one the superficial, which is kind of safer because it's kind of farther away from the ribs and the pleura of the lungs. So we are kind of avoid even complications. All right. So this is a video of one of my patients here, just to describe the anatomy a little bit of you. I'm moving here from posterior to anterior. Right there, we have the latissimus dorsi and we have the serratus anterior, and we move anterior, the latissimus goes away, and then the serratus is inserting anteriorly into the ribs. We can see also the intercostal muscles in between the ribs and then the pleura deep to it. And we have here a diagram that we can see the latissimus with the option 1 of the injection and then option 2 deep to the serratus. We have to avoid the thoracodorsal artery. We can identify it in this plane. So it's something that we can definitely look for. And you can see it in the video kind of traveling in that plane, in that area. So how do I do the injection? So I have the patient laying on their side, and they have their arm a little bit forward flex to get it out of the way. And that way we bring the latissimus dorsi more into plane. in that location so you have a clear picture of the plane that we're injecting. And we're going to go kind of distal to proximal and kind of lateral to medial in this approach. We can use like a 25 gauge, 1.5 or 2-inch needle. I do a mixture of triamcinolone and 20 milliliters of ropivacaine or lidocaine, any anesthetic. I inject a lot of volume in that area because it has been shown that the most important thing that help the patient is the volume. Because if we inject more volume, more fluid is going to spread through that space, and the higher chances of the pain improving. So that's why I inject 20 milliliters if it is still safe in patients. And then pitfall would be to avoid the thoracodorsal artery and nerve and the lung thoracic nerve, and definitely avoiding the lungs and the pleura to avoid pneumothorax. This is the spread of one of my injections. You can see here the needle in between the latissimus dorsi and the serratus muscle. You can see a video here of the needle getting in space, and all this kind of dark anechoic region is the fluid spreading in that area in order to get a good spread and have good results. It doesn't work on everybody, but I'm having like the majority of the patients respond very well. I will say that it's not always 100% results, sometimes like 70, 80% improvement. But for the patient that have been having this pain for 5, even 10 years, having 70% improvement actually is excellent, and they are very happy with the results. Another injection that we can consider is the intercostal brachial nerve block. Like I said before, the intercostal brachial nerve is a nerve that kind of come from the T2 level of the intercostal nerve and cannot travel in the proximal arm. In surgeries, it can get injured, and we can identify this under ultrasound. It's kind of very close to the axillary kind of vessels, and you can see it over here in this area. There's a way that we can identify and do the injection. This is an article by Dr. Wysotsky that kind of describes his approach of doing it with the shoulder abductor 90 degrees and externally rotated. And we can use like a less volume in that case because we're identifying the nerve and injecting around it. We just have to avoid the vessels in that area. However, I don't tend to use this approach a lot. I tend to use this plane approach a little bit better because I don't know at what point the nerve got injured. So if we inject the nerve distally to the injury, I don't feel that it's going to be very helpful. So that's why I go even proximal, very close to where the nerve kind of transition to the arm. And we do this kind of what we call the serratus anterior T2 plane block. So we're doing a serratus anterior plane, but very, very proximal and superior at the between the second and third ribs to make sure that we block that intercostal nerve. And then since it's a plane block, I tend to inject a little bit more volume, like 10 milliliters in that case. These pictures, we just got accepted for an article that is going to be describing all these plane blocks and how to do them. So hopefully that will come up in the next month or two in the pain practice journal. So more people are feeling more comfortable to offer this option to patients with this problem. So that will be coming up also in the next couple of months. Another injection that I do in some patients, especially when they have more pain anteriorly instead of lateral, with the serratus anterior, I do it more when the pain is more lateral. When it's more anterior, I tend to do like a PEC 1 block or the interpectoral plane block. When we identify the PEC major muscle over here and the PEC minor, and we inject in between the two muscles. We inject 10 milliliters of anesthetic and 1 milliliter of steroid. And then we just have to avoid the thoracoacromial artery that is right here. It's very easy injection to do. It's important to identify if the patient have implants, like breast implants, to make sure that we avoid it and don't poke it, right? Which is another pitfall with this injection in this population. The idea of that injection is that if we cannot block the medial and lateral pectoral nerve, it cannot deactivate the pectoralis muscles a little bit and decrease the tension and the tightness in that area to see it kind of decrease the pain, and they can do a better job with the rehab portion. Sometimes I do also like a trigger point in the muscle at the same time to see if that helps also with the patient. Another option is kind of going a little bit deeper into the pectoral serratus plane block, which is very similar to the T2 serratus plane block that we did. We just have to do it a little bit more lower and distal. But it's kind of the same idea. With this approach, we tend to put some fluid in between the pec muscles, but also go a little bit deeper and put it on top of the serratus and deep to the pec minor muscle. All right, so let's move on to different other conditions. Another condition is a possible injury of the long thoracic nerve, um, which can be seen sometimes when they do breast cancer surgery. Like we know, the long thoracic nerve arrives from the C5 and C7 roots. It passes behind the brachial plexus and enters the axilla, where it can get injured when they do surgery. It innervates the serratus anterior muscle, so you can develop winging in some patients. There's different reports in terms of the uh, prevalence and incidence of this from 0.6% to 70%. And one study described in 264 breast cancer patients that 11% have some long thoracic nerve injury. However, 90% of the cases, the injury is kind of partial. It's more like maybe traction, and they tend to improve after rehabilitation. This patient actually is not a patient with breast cancer. He had other surgery that developed long thoracic nerve, but I find it very interesting, the video of how can you see the winging in this patient. You can see it right there. So in this patient, actually, we brought the patient to the clinic and we did an evaluation of the serratus anterior. And the ultrasound application here is that you can help diagnose muscle atrophy by measuring the thickness of the serratus. And you can see the difference here from 0.47 centimeters to 0.71 centimeters. But you can see it's very obvious, the thickness. So that kind of help with the diagnosis. And it might be more academic than anything else, but it was kind of nice to see the ultrasound application on these patients. Another very common thing that most people see in their clinic, but especially I see in my breast cancer clinic, is adhesive capsulitis of frozen shoulder. Like we know, this is an inflammatory process causing kind of fibroblastic proliferation of the joint capsule that can lead to thickening and kind of fibrosis of the capsule that can limit the range of motion and create a lot of pain in patients. It's more common in females between the age of 40 and 60, which is a very popular age for breast cancer. We see it between 50 and 59 have an increased risk of adhesive capsulitis if they have done a mastectomy. I tend to do an x-ray to make sure that the patient do not have osteoarthritis, which is another reason that can cause range of motion limitation. And I cannot do a good physical examination that if the external rotation is very limited, then I'm suspecting that the patient have adhesive capsulitis with a normal x-ray. Because shoulder impingement can restrict the abduction action, but it should not restrict the external rotation, and that's more consistent with adhesive capsulitis. So let's start talking a little bit this. As we know, adhesive capsulitis is a condition that the good news is that it goes away. The bad news is it can take like 1 to 2 years to get better. And we can see here in this diagram that usually there's 3 stages of the frozen shoulder. One is the freezing stage, where it's very painful and the range of motion is getting bad. Then at some point, the pain at rest get better, but the patient feels frozen. And when they try to move it, it's painful. And then eventually, hopefully, it starts getting better until it goes away. The long-term outcome, like the average, it has been described as 1.6 years, with 91% returning to normal activity. There's some risk factors of developing this. Like I said, females are a little more common, but if you have diabetes, thyroid problems, strokes, or breast cancer surgery. So mastectomy has been found to increase the risk of adhesive capsulitis, and reconstruction surgery also have a risk of developing this. So this is something that I see a lot in my practice. Radiation therapy has not been kind of correlated specifically, but definitely it can add to the process of frozen shoulder. So what is the treatment? And number one is time. We have to be patient with this. It usually goes away, but it just takes a long time. But in the meantime, we need to kind of address the pain and some of the symptoms of the patient so they're not struggling, because the pain can be very severe and difficult. So there's some oral medication that, again, I'm not a fan of oral medications, but it's an option to consider. Physical therapy can be considered to incorporate some gentle stretching, physical therapy strengthening program. And there's some procedures that we can consider, and we're going to talk a little bit more. And eventually, if the symptoms do not improve, there's some surgeries that they can offer, like capsular release, manipulation under anesthesia, that can be considered at some point. So let's talk about injections and kind of ultrasound application. So it has been found that actually the injection is kind of superior, improving the patient's symptom faster than physical therapy. But the combination of both, it seems that is better than either one by itself. Instead of injections, it seems that intra-articular shoulder injection have better results to relieve short-term pain when we compare with subacromial steroid injection. So I tend to do intra-articular. And then there's another option that we call the high volume hydrodilation of the shoulder capsule. That study has showed that it seems that it can be superior, improving pain, function, and range of motion compared with a simple steroid shoulder injection. So let's get some data here and some evidence. So let's talk about the ultrasound guided high volume capsular distension or hydrodilation. So it seems that it's superior to other conservative approach. Capsular hydrodistension with steroid plus physical therapy is found that is superior to just physical therapy by itself. Basically, the idea is doing like a shoulder joint injection, but injecting like a higher volume so we can expand the capsule a little bit more and kind of release a little bit of the scar tissue in that area and see how that kind of improve the symptoms a little faster. One of the big questions that we still have is what is the optimal volume that we should inject into the shoulder? And depending on who you ask, he's going to give you a different answer. For the last couple of years, I've been asking this question when people present about frozen shoulder, and I get a different answer every time. Sometimes they have providers that inject like 20 milliliters of fluid, which is my case. And I have other one that inject like 40 and 50 milliliters and even more to try to break the capsule and collapse the capsule to try to release those tissues. So let's start talking a little bit more about different approaches that we can do this injection. So we have the anterior approach. With the ultrasound, we find the rotator cuff interval. When we have the bicep tendon, we have the supraspinatus tendon and the subscapularis tendon. And we have the coracohumeral ligament right superior to the bicep tendon in this view, and the superior glenohumeral ligament inferiorly in this area. So the injection can be right on top of the bicep in between the coracohumeral ligament, and the fluid will kind of travel intra-articularly. The other approach is the posterior approach, that we kind of go to the posterior shoulder. We find the glenoid and the humerus. We have the infraspinatus right on top, the deltoid more superficially, and we kind of guide the needle into the joint. And we see actually when they have true frozen shoulder, you see that expansion of the capsule, and you're creating this kind of expansion of the capsule with the volume that you're injecting. There's like 2 or 3 articles out there that they compare both approach, and most of them found that the anterior approach seems that is superior to the posterior approach. Both helps, so both are good options, but it seems that the anterior might have a better outcome. And the theory behind it is that we're injecting very close to the coracohumeral ligament that is suspected that is the ligament that gets tighter with adhesive capsulitis. So if you're injecting right next to it, you're having better anti-inflammatory effect with the steroid in that area. So these are some videos. You can see the needle coming in play here in the posterior approach, and we're kind of injecting right there in the shoulder capsule on top of the humeral head. And you can see that I'm going to wiggle the needle here for appreciation that the needle tip is in the right spot in this area. And when we inject volume, you can see the expansion of that capsule and hydrodilation, which usually is consistent with adhesive capsulitis. If you don't have adhesive capsulitis, usually you don't see that expansion of capsule with that kind of volume in the shoulder. We have the anterior approach, which we can see the needle here right on top of the bicep tendon, deep to the coracohumeral ligament, and we inject the volume there. So the idea is you don't see any fluid accumulating in that area because it's going into the tendon sheath and into the joint. And after, I tend to kind of do, I put the ultrasound probe posterior in the shoulder where you see the glenoid and the humerus, and we can confirm that actually the fluid went into the shoulder capsule after, to kind of confirm that the good placement of the fluid. So that brings me to the question, should we be injecting a volume that kind of preserve the capsule just to keep it distended, or do we want to kind of rupture the capsule and inject more volume? They did one study that determined with kind of a needle that can measure the pressure that around 25 milliliters plus minus 6 milliliters is where the capsule kind of ruptures. So if you want to preserve the capsule, I tend to recommend between 18 and 20 milliliters to ensure the preservation of the capsule. The benefit of this is that we keep that distension for longer term, that some people believe that it gives the patient better results, but also the steroid stays inside the capsule to create that inflammatory control, that it can be beneficial. If you want to break the capsule, the kind of, in my mind, the contraindication is that the capsule tend to rupture at the subscapular fossa, which is kind of a weaker area of the young capsule. And usually it's not the problem of frozen shoulder. You're not breaking actually the capsule where the problem is. And then you're losing all that fluid into the soft tissue. So it can create like some atrophy, and because you're putting steroid in kind of the soft tissue. And then the steroid most likely is not doing the effect because of the breakthrough of collapsing of the capsule. However, it still works in my opinion, but I kind of prefer the capsule preserving approach, at least at this time, with the knowledge that I have. All right, we're just finishing up because I wanted to make sure that we have enough time for questions. But one of the things that I wanted to address is the aromatase inhibitor associated musculoskeletal syndrome. Patient with breast cancer, depending of some cancer types, the oncologist place the patient in an aromatase inhibitor. This is a medication that the idea is to decrease the estrogen in the receptor positive breast cancer patients, so we can decrease the recurrence of the breast cancer to coming back. So it's very important. The problem is that since you're decreasing the estrogen, you're developing a lot of side effects from this medication, and a lot of patients cannot tolerate this medication very well because they start developing joint pain, arthralgia, joint stiffness. They wake up in the morning with a lot of stiffness. They have bone pain. It's kind of very similar to kind of fibromyalgia in the sense that they have pain kind of all over in the hands, and it's affecting a lot the quality of life, but it's secondary to the medication. Very interesting, these patients also start developing like trigger fingers and kind of carpal tunnel syndrome as part of the side effects of the medication. So the way that we tend to treat this is exercise is very important. It has been shown that if you increase the exercise routine, the side effects tend to improve. There's some oral medication that we can consider, physical therapy we can consider, sometimes injection and acupuncture can be a good option. But I feel that exercise is one of the best options to try to treat these patients. So I spend a lot of time talking about exercise and creating an exercise program for these patients for different reasons. Number one is to mitigate the side effects of some of these treatments. But number two, it has been shown that patients that are more active and have a good exercise routine, it decreases the chances of the cancer coming back by 24%. So that's a very important concept to tell patients that by exercising, you're still fighting the chances of the cancer coming back. There's another studies that also showed that patients that exercise 30 minutes 5 to 6 days a week and eat 5 to 6 portions of fruit and vegetable per week, decrease the chances of dying from the cancer by 50%. So there's a big role in exercise in this population. So I tend to kind of be very specific of the exercise routine and how can we optimize it to try to help patients. Going back to the ultrasound application in this patient, like I said, this patient developed a lot of carpal tunnel syndrome. So there's injections that we can perform and do like a hydro dissection of the median nerve at the level of the carpal tunnel to kind of decrease the symptoms. They develop a lot of trigger finger. You can see in the video here the movement of the flexor digitorum tendon getting stuck underneath the A1 pulley, which is this area over here that is thicker. And we can do an injection in that flexor tendon sheath underneath the A1 pulley to kind of decrease the symptoms of trigger finger and see how that helps. So that's another ultrasound application that we can apply in these patients. So just to finish up and make sure that I have enough time for questions, many of these issues are similar to other patients, not necessarily to cancer. So we already have most of the knowledge that we need to do to treat these patients. We will have to maybe learn a few differential diagnoses that are more specific in this population. Um, it's a learning process. So I started seeing this patient without seeing them before. So I just started doing it. And slowly, with every patient, I learn and learn and learn to the point that I'm seeing 7, 8 patients per week of this problem. And I think that I'm affecting their life in a positive way that is very rewarding to see, to the point that they go back to their oncologist and saying how good they're feeling. And then now the oncologist is sending a lot of patients. And the other point that I'd like to say, I'm a sports doctor, so I enjoy a lot talking about exercise. And I spend a lot of time talking about exercise to this population, which is always kind of fun for me to do in clinic. So just a thought to finish my presentation. This is Jimmy Valvano. He's one of a college basketball coach. Like I said, I'm a sports fan and a sports provider. And so I always try to apply the sports knowledge into my presentations. And he developed cancer and he died from cancer. And if you look in YouTube, you can find one of his most famous speech that I think is very good to listen um, because it's very rewarding. And one of the things that he said is that cancer can take away all my physical abilities, but it cannot touch my mind, it cannot touch my heart, and it cannot touch my soul. So I kind of always try to encourage doctors to try to help patients with cancer because they're struggling, and I think we can make a big difference in their life. This is my email and my Twitter. In case that you want to contact me for any questions, I'm happy to help and give you some insight. So now I kind of open for questions and kind of address any concerns that you might have.
Well, thank you, Dr. Raul, for such an extensive lecture that you've given us today. So thank you very much and congratulations.
Thank you.
Okay, I have a couple of questions though. Let me just give the first one. The first question would be, I've seen your ultrasound injections over the area between your latissimus dorsi and your serratus anterior approach, where you were actually hitting the superficial branch of the intercostal nerve. Now, I wonder if, because I've seen some persons doing an approach where they go directly at the inferior border of the rib itself, where there are the vessels, including your intercostal artery and nerves at the same time. Some people feel this is very safe, although I feel this is very dangerous as well. But would you like to comment on that instead of the technique that you're using, where you just hit the superficial branch? Would there be more?
Can you mention which approach you're describing? Sorry.
Okay. Because you presented the approach where the intercostal nerve superficial branch is being hit at that area where you actually shown us, but there are pain physicians who are doing it at the inferior border of the rib itself, where you find
Okay, got
the
it.
intercostal
Yep.
vessels, the nerves and the arteries.
Yep.
would you like to comment on this, the safety
Yes.
of the procedure?
So yeah, those are options, right? No, there's no one better than the other, at least that we know at this point. And when we go deep to the serratus anterior and right on top of the ribs, and that's are the deep fibers of the lateral cutaneous branch, which is another good approach, and it has been shown that it can still help. I tend to use that when patients have a lot of scar tissue from radiation, that the skin is kind of very tight. And when I put it superficially, I don't get like a good kind of opening of the plane between the latissimus and the serratus. So I tend to prefer to go deep to the serratus because I felt that the flow of the fluid is a little bit better. The other approach that people can do is in between the ribs into the intercostal nerve itself. So that's another option. The problem that I have with that one is that you're targeting only one intercostal nerve that is in that region instead of more of a plane. So you have probably have to do multiple blocks into multiple ribs in between ribs to kind of inject that nerve. The other thing that kind of work on my mind is that at that level, you should not have any injury of the nerve because the surgery do not go in between the ribs. It stays superficial to the rib. So I feel that the nerves that are being more involved are actually the cutaneous branch of the intercostal nerve. So that's why it makes more sense in my mind. But yeah, those options are good options. It doesn't mean that it's not going to work. It's just that the way that I visualize the problem, I tend to prefer that approach. And there's two studies that compare the superficial and deep approach of the serratus with not big difference. So in order to stay away even further from the ribs, I tend to prefer the superficial approach more. But I have done both.
Thank you very much, Raul. I have some questions from the chat box. Would you like to raise a question, Pash? Dr. Pash is like the president of our Philippine Academy of Rehabilitation Medicine in the National Capital Region. So I'd like to introduce her to you. So Pash, can you speak up?
Yes, hello. Good evening from the Philippines, doctor. Thank you very much for that wonderful and very comprehensive lecture. Can you hear me?
Yes.
Yes, okay. So I have two questions, doctor. The first being, have you ever tried using dextrose D5% instead of using steroids for your hydrodissection? And the second one is, can we combine doing suprascapular nerve block injections with doing their hydrodissections? Is there an advantage doing that? Thank you very much.
Yes. Great questions. Number one, yes, at some point when I started doing these injections for these patients like 4 or 5 years ago, I kind of switched to try to incorporate more dextrose to increase more volume and decrease the anesthetic approach because, like probably the reason that you're asking, there's some role in terms of the stability on the membrane of the nerve when we inject dextrose. But I wasn't happy with the results compared with the numbing and kind of steroid approach. It still kind of work, but I didn't notice like a big difference from both. I probably didn't try it as much as maybe I should. It's a good option that I think it should be studied and maybe compare and see the difference because it has some logistic behind it. So I think your question is very smart in that sense. Uh, but there's no data behind it. And I didn't notice like a big kind of result from that. In terms of your other questions, yes. The answer, I forgot to mention that I tend to do for hydrodilation of the shoulder capsule. Uh, it's very uncomfortable for the patient. So I tend to do before we start a suprascapular nerve block for different reasons. Number one, to decrease the discomfort of the procedure so the patient can tolerate it a little bit better. And number two, there's some people that believe that actually the suprascapular nerve block has a role in helping with adhesive capsulitis, and it helps. And I have some colleagues that actually offer that injection only to help with the patient with the pain of adhesive capsulitis. So in the case that it's also helping, then I want to do it also to try to help the patient before the procedure. I tend to find that when we do the posterior approach of hydrodilation, it's more uncomfortable than when we do the anterior approach. So definitely, if you do the posterior approach, I feel that the suprascapular nerve block is very beneficial. I've been doing recently the anterior approach without the suprascapular nerve, and the patient tolerated pretty well. But it's something a good option that I still offer some patients to do. It's another good approach. Yes.
Sorry, doctor. When you do that suprascapular nerve block, what do you use? Thank you.
So yes, so I tend to use a mix of lidocaine and ropivacaine. I tend to put like between 2 or 3 milliliters of lidocaine and 2 or 3 milliliters of ropivacaine. My logistic of doing that is the lidocaine kind of work faster, but then it only gives you like 2 hours of results. The rope it take a little more time to work, but it gives you like 5 to 8 hours of results. So I want to give them like a good, like at least a good night to the patient that decrease the pain. So I tend to do like a mixture, so it kind of work fast, so I can move faster and do the hydrodilation, so I don't have to wait a long time, but also gives you like a longer result in terms of pain relief for the patient.
Okay, Pash, thank you very much. There's another question from Doc Mel. Doc Mel, can you speak up?
Thank you, thank you, Dr. Jim. Congratulations, Dr. Raul, for a novel discussion. Having two sisters who actually suffered from breast cancer, but eventually died, but they were actually survivors for a long time. I have two questions in retrospect, Dr. Raul. The first question is, what injectates could have been given? Both of them are actually in the US and in California for that matter. I know they have so much pain because they were actually here and I was actually there when they have breast cancer too. So what injectates could have been given to them for their, most of their pain was actually upper limb pain and chest
It was
discomfort.
in the chest wall, in the
Chest
outside
and
here.
the shoulder.
Yeah. Yeah, so number one, sorry to hear that news, right? And that your loss. And number two, so if the pain was kind of more in the lateral chest wall, I tend to prefer the serratus anterior plane block that we were been discussing. I feel that patients are responding pretty well to that. They're having like between 70 to 100% of relief, and I have noticed some improvement. I want to kind of emphasize that I tend to make sure that the patient also understand that we need to do like a good therapy program and rehab program. So the idea of the injection is maybe try to decrease the pain, maybe they sleep better, they're more active, but then we need to focus on that kind of biomechanical addressing the biomechanical approach and and strengthening a stretching program that I think is going to be beneficial. If they develop frozen shoulder, then it would be a different injection, would be the high volume hydrodilation of the shoulder capsule. And so one of the main reasons that I've been publishing a lot in this topic is that I feel that this injection and these procedures are not commonly offered in patients. I have had some conversations with some providers that are treating a lot of cancer patients as part of the rehabilitation approach, and now they're starting to offer these injections more. So it's something kind of newer in that sense that not a lot of providers are offering it. That's why I just hopefully we publish that article of how to do it and teach it, so more people do it, and also the article about how to treat this kind of problem as a comprehensive approach, because it's something that most of the oncologists and surgeons just address like it is what it is, and you're alive. It's one of the complications that happen after surgery, but without nothing that we cannot help with the patient. But now we're transitioning to try to offer these options, and I have noticed that the patients are very appreciative of these options.
Thank you, Dr. Raul. My second final question is there a particular set of exercises for these patients, even if they don't have a frozen shoulder or chest discomfort? Because you said
Yes.
that exercise will actually benefit these patients.
So yeah, talking about the general sense of exercise. So if we talk into details, there's two type of exercise, right? We have the aerobic exercise and the strengthening exercise. So for the aerobic exercise, we want to achieve at least 150 minutes of aerobic exercise per week. However, we're not going to start with that because most of the patients that I see are not used to exercising. So if we start that high, they're going to quit or get injured or something. So I tend to tell patients, let's start by walking 20 minutes 3 times a week. And then we're going to optimize that exercise routine slowly by addressing the three things that we can do, which is optimize the duration. So instead of doing 20 minutes, we do 25 minutes and 30 minutes eventually. We can optimize the frequency. So instead of doing 3 times a week, we do 4 times a week and 5 times a week eventually. And we can optimize the intensity. And the way that I incorporate intensity in the formula is that I tell patients to incorporate interval training. Interval training is when we go up and down in the exercise intensity. So I tell patients walk for 5 minutes and then do a power walking for 1 minute. So then you continue with this kind of 5-to-1 ratio until eventually you feel comfortable, and then you want to do 5 to 2 minutes, and then 5 to 3 minutes, and then we're increasing the intensity slowly, and the patient kind of address it. I give the patient usually a table, which kind of the rows are the weeks, and the columns are duration, frequency, and intensity. So they can kind of write what they're doing each week. So when I see them back, we can kind of take the next step. The other important aspect is the strengthening program that you should be doing it 2 or 3 times a week. Especially in breast cancer, you have to do all body, like upper and lower extremity. But in breast cancer patients, I like them to focus a lot on stretching of the pectoralis muscle and strengthening of the scapular muscle. So I tell them to do a lot of rows, external rotation and internal rotation for that shoulder to try to protect it.
Can I add a final question, Dr. Jim and Dr. Raul? I just recently attended a strengthening conditioning conference. So my question is, how do you bridge the world of the strengthening conditioning coaches in the US and the physiotherapists? Because they're not actually the same, but they have to be
Correct.
interconnected. And I'm saying this because you were discussing some aspects which are actually SNC, but not physiotherapy. Thank you.
Correct. That's a great question. So this is how I address that. If the patient do not have any pain and we just want to do like optimize the exercise routine and there's nothing that we need to address with rehabilitation, I tend to use more of the personal trainers and exercise physiologists kind of approach because there's nothing concerning that they need to be, there's contraindication for them to kind of be, have a precaution. Um, if they have a concern, like I have back pain, I have shoulder pain, so I tend to start with some physical therapy approach. They're trained to optimize the exercise routine also, but in addition, they're addressing the complaint of the patient. Uh, at some point, they cannot do physical therapy forever, so I want the patient to transition to the exercise physiologist, right, and use the personal trainer approach and continue to the home to do the home exercise program. So I use them like a continuum in that sense, to try to address it. There's some studies that says that supervised exercise at the beginning, that they have a trainer or the therapist is supervising a little bit more like weekly, have a very better result because the patient tend to do it more than when the patient tend to start by themselves. So yes, supervision and personal trainer has a big role in that. And here in the US, there's even some credentials that some exercise physiologists can have that specialize in patient with cancer.
Thank you very much, Doctor. Thank you. Thank you, Dr. Jim.
Yeah, thank you very much. One more question I think would be us, most of us here are doing other injectates, as mentioned earlier. Um, Maybe the use of other modalities like 5% dextrose and maybe PRP and other related thing. Would this be a possibility, especially if this is a breast cancer? Because we know it could probably just spread the cells once
Correct.
we do these things. Okay. So would you comment on that?
Yes, so that's another great question. These all are excellent questions, great questions. So in terms of the dextrose, no big concern from my standpoint. and I think it can be used as an option, like we discussed before with the serratus anterior plane block. In terms of PRP, I tend to be a little more careful because we're taking your blood that we don't know if it has like a few cancer cells that they were injecting in a different area. For the general standpoint, if the patient is not active during treatment and it has kind of is more than at least like 6 months or a year after their cancer, I'm okay considering PRP for different conditions. I don't tend to offer it for the options that we discussed, but if they have other issues like rotator cuff tendinopathy or other issues that are not related to the cancer, I think there's still a big role that we can offer them. I tend to discuss it with the oncologist first to see if there's any concern. And if they give me the green light, I tend to offer it. That should not be the case with the other kind of stem cells modalities, with the BMAC and lipogems and all those things, because at that point we're taking cells from the bone marrow and things like that, that I think in theory it's recommended to wait 5 years after you've finished the cancer treatment to consider those options. Again, these are just opinions of experts that do these procedures, that it's just a precaution. Probably there's no data and there's not going to be ever any data, because we're not going to probably try it and see if you get cancer or not, or remove it. But it's just a precaution that we tend to have, and we try to wait 5 years after treatment in most cases.
Hey, Dr. Raul, one last question. This is just the last, I think. Okay, Dr. Amador, I think you would like to raise your question. Would you like to do that now? Hello, Dr. Amador.
So I don't know if the question is in the chat. I think
Yes,
Amador kind of
yes.
put in the chat. So the question is if there's any contraindication for doing injection for patient with breast cancer stage 4 post-mastectomy experiencing shoulder pain or frozen shoulder. I have metastasis in the third rib. So there's no kind of true contraindication if you're not injecting the area that has the cancer. So if the metastasis is in the ribs or in the lower extremity or in the spine, there's no problem that you can do the steroid injection or high volume injection into the shoulder. It should be no problem at all.
Doctor, one last again. I don't know how many last questions we have. Anyway, my question is, Doctor, how long do these patients usually stay pain-free post-injection? And do we repeat injections if ever they do get pain again? How soon can we do it? Thank you.
Yeah, another great question. So it kind of varies a lot. Some patients we do it once and they do rehab and the pain never comes back in terms of the post-mastectomy pain, and they're very happy and I never see them again. Other patients has remained with some pain that it comes back like 3-6 months later, 1 year later. So I have repeated the injection in some patients. I have done it like 2 or 3 times in some patients. I try to separate it at least 3 months apart. If at some point the pain always come back, I try to address if something else is going on, because usually in my experience, those patients also have fibromyalgia, they have poor sleeping patterns, they're not sleeping very well, they're depressed, there's anxiety. And I tend to, at that point, use the more comprehensive approach that we treat the amplifiers of pain to see if we can have a better long-term result than just doing this injection every 3 or 4 months. So I kind of try to switch the approach in those patients. But the majority, usually I do 1 or 2 and they're okay.
Thank you, Dr. Raul, for such a very comprehensive lecture today. And I know all of you are on vacation, but still you find time to come and listen to this wonderful lecture today that Dr. Raul shared to us this morning and this evening. And so we gladly thank you, Dr. Raul, and hopefully we can meet sometime again next year. And I'm trying to invite him in our future courses, and probably Dr. Raul can come. He's very young, so he can travel. There's no restriction, right, Dr. Raul?
Exactly. I enjoy traveling, so I appreciate number one the invitation for today. I'm glad that everybody was able to join and hear me talk here before the new year, and I'm happy to kind of continue to collaborate in the future because I think that's key in terms of helping each other kind of move and help patients and kind of move forward the knowledge, which is kind of a passion of mine. So I'm very happy that you invite me today to kind of share my knowledge.
Yes. Thank you very much, and I thank everyone also for coming. And for those of you who have not who failed to start the lecture, we'll try to make this available, and I'll let you know where you can find them, and we can all share this to our colleagues eventually. So thank you very much, Dr. Raul, and God bless.